Thank you, Despina. Good morning, everyone. We are extremely pleased to welcome Dr. Stephen Simpson as our opening keynote speaker. Dr. Simpson is a professor of medicine, director of fellowship training, and the associate division director for pulmonary and critical care medicine at the University of Kansas. He also chairs the critical care committee and is the co-chair for their sepsis team. Dr. Simpson has been an innovative leader in both critical care medicine as well as quality improvement initiatives. He is the founder of the Midwest Critical Care Collaborative. This is a multi-state, multidisciplinary effort to improve the quality of critical care services throughout the Midwest. As you will appreciate today, Dr. Simpson's research career has been quite rich and has spanned all areas of severe sepsis, from molecular and cellular mechanisms to translational and quality improvement studies. In 2009, Dr. Simpson founded the Kansas Sepsis Project. This is a statewide effort to reduce mortality from severe sepsis at least 10% by the year 2015. The Sepsis Project incorporates a continuing education program on the latest best practices for sepsis care to providers across the state. For his work, Dr. Simpson was recognized as a distinguished scholar in critical care medicine. This is one of the most prestigious awards given by the American College of Chest Physicians. This is in support of important critical care projects. The Sepsis Project's innovative approach to education, recognition, and management of sepsis has been also adapted for rural hospitals. As a native of Western Kansas, Dr. Simpson has provided education and support for hospitals in rural Kansas locations for over 15 years. And somewhere in his spare time, Dr. Simpson and his wife, a leading pediatric surgeon, have managed to raise 2 sons, now both in college. Dr. Simpson shared with me this morning that his youngest is finishing up a degree in chemical engineering at KU. He is now deciding whether or not to continue on to medical school, like his parents, or maybe to establish a microcraft brewery. What choices will he have? Please join me in welcoming Dr. Stephen Simpson.
Thanks, Diane. And I know now you're all going, gee, this guy doesn't look good enough to be what she just described, and you're probably right, I'm not. So yes, my background is in severe sepsis. I do have interest in informatics, but it was due to that interest that I got involved with our project at the University of Kansas Hospital and helped to evolve an informatics-based approach to severe sepsis in our hospital. And that's what we're going to get at. But one of the things you might be also able to tell from my introduction is that I don't ever leave any audience without trying at least to be sure that each and every one of you goes home to wherever you are and goes, wow, that sepsis sounds like a problem. We better figure this out. So we're going to spend about half our time talking about what is sepsis, with a mind toward what about this stuff that sepsis is might be useful from an informatics perspective and how can we use it. And hopefully I convince you to do that. Now, let me get, HIMSS audience is a little bit tough for me because I know there are some people in here with no actual clinical background at all. Could I see a show of hands on that? Mostly IT people, sometimes business folks. Okay. There are some folks who are nursing background. Can I see that show of hands? Yep, a whole lot. Some folks that are MD background. Yep. Okay, good. So this can be a challenge because I can't use fancy words when I'm talking to different people, so we'll be careful about that. The value of real-time surveillance. Okay, I want you to stop for a second. This is your brother, this is your uncle, this is your dad, and or, so I want you to look from 2 perspectives. One perspective is that. Second perspective is you're working in the emergency room and you see this gentleman here. So what does this guy do? A 72-year-old man presents with flank pain and fever, and his wife brought him in because he was hurting so bad. back of his back right here. He has previously had a ureteral stent placed. Ureters connect kidney to bladder. He has a history of coronary artery disease and hypertension. He's taking a bunch of medicines for blood pressure and for prostatic hypertrophy and for cholesterol. These are his vital signs: 105/43, tachycardic, tachypneic, kind of febrile, O2 sat 87%. So what this guy has, for those of you without a clinical background, is a kidney infection. Okay? He probably has plugged up his stent that's in his ureter. He's got a kidney infection. Every ER doc will tumble to that diagnosis. So the question is, you're the ER doc, you're the ER nurse, or this is your brother or uncle, what do you do? So these are the choices. You can either give them oral antibiotics and send them home, give them oral antibiotics, put them in the hospital. You can give them IV antibiotics, put them on a hospital floor, or you can get the heck all over it, send them to the ICU, bolus them fluids. Now, from the introduction you just got, you can probably guess what the answer is going to be. From my actual data from my own hospital initially, and then from other hospitals across the state and the Midwest, and frankly across the nation, I can tell you this is the number one choice when this is the number one answer. A little bit more data that we won't use right now, but we will use when we come back in a bit. Severe sepsis, the most feared and the most severe consequence of an infection. When you hear that somebody has died from a pneumonia, somebody was in the hospital for a surgery and they got a wound infection and they died, they're not dying from the infection per se, they're dying from the sepsis. The sepsis is the response to that infection that involves system-wide problems, blood clots happening in capillaries all over the body. It involves organs of various types, and it's that organ involvement and starvation for oxygen that causes people to die. How many people do die from this? The in-hospital mortality from severe sepsis is 300% of that of acute MI. Well, only a fool would present a question like this and have the answer not be true, so I'll just tell you the answer is true. Severe sepsis is fatal 30 to 50% of the time. 30 to 50%. The worst that acute MI ever did for in-hospital mortality was 8 or 9%, 14.5%. That was before we had thrombolytics, clot-busting drugs. In the days when all we could do was put them in the CCU and watch, 14.5% died. As soon as we got thrombolytics, that took it down to 9%. And now that we have in our hospitals, as I'm sure your hospitals have, coronary angioplasty for acute MI, it's down to about 7.5%. So quite clearly, 30 to 50% is at least 3 times what the baseline mortality was of 14.5%. This is a killer. Severe sepsis, in fact, is the major killer worldwide, and we all know that worldwide people die from infection, right? That's the number one killer in the world. Severe sepsis does it. However, in the United States, if you have to go in an ICU for any reason, other than the CCU, for any real ICU, if you have to go in there for any reason, the single one thing most likely to have you brought out in a body bag is severe sepsis. This data that I'm showing you right here was collected in 2001. The data was collected in 1995. It was published in 2001 by Derek Angus. In 1995, there were 750,000 cases of severe sepsis, and 500 people a day were dying from that condition. The reason we quote this study, this was the first really well-done epidemiologic study that gave us a good handle. And so we, to this day, almost 20 years later, 10 years after publication, we still quote that. Based on those same data, look at this. This is number of deaths per year from AIDS, which was considered in 1995 a big killer, breast cancer, acute myocardial infarction, and severe sepsis. In 1995, severe sepsis was killing just as many people as acute myocardial infarction. And nobody had heard of it. And in fact, to this day, your average person on the street has no idea about this condition, even though it's one of the biggest killers in the United States. Half the people that die from cancer, all the deaths that are attributed to cancer mortality statistics, literally 48% of those are due to infection, i.e. due to sepsis. It's probably the #1 killer in our country. And it's growing. It's been growing for years and years. This is a paper published in 2003 in the New England Journal where they looked at the time period from 1979 to 2001 to see what's the incidence of sepsis doing in this country. And Greg Martin, who by the way is a Kansas boy, I'm glad to say, working at Emory University in Atlanta when he published this, but he's a Kansas boy, showed 8.7% per year compounding increase. Compounding, 8.7. A few years later, Victor Dombrowski took another look, slightly different methodology. From the time period 1993 to 2003, same thing, 8.5% per year, compounding growth. Let me ask you, who in here has a retirement fund that's growing at 8.5% per year? Boy, don't we all wish we did right now. That's what they promised me back when I started putting my money in the stock funds, right? Back when I was younger. Yeah, historically it grows at 8% per year. Well, it hasn't been the case in the last few years. However, 8.5% per year, what does that mean? What that means is that the number of cases in the United States doubles at approximately, oddly enough, every 8.5 years. So, 1995, 8.5 years, 2003. Another 8.5 years, 2012. If you double from 750,000 to 1.5 million and double again to 3 million, 3 million cases. And not 500 people a day, but 2,000 people a day. 2,000 people a day. Now we happen to know, based on some of our work, that at least half of those deaths are unnecessary. They don't have to happen. And that's part of what my whole career has been about. Now, take a look at this. Also from the 1995 data that Derek Angus presented, and he broke it down by age groups here. He's got two things on this slide. He's got incidence, which means how many cases per 1,000 population. He's got absolute numbers of cases on this one. This is absolute number of cases. This is incidence. Now, if you look at the incidence curve, you see as you get older, it gets slightly more common until you get about age 65. You hit age 65 here and boom, what happens? It goes up 15-fold between 65 and 80. So the people in that age group are highly, highly susceptible. Now, what else about this graph is interesting? Over here, right in here, see this big bump, sort of like a hump on the snake, so to speak, the snake that ate the big rat. There's a hump right here. And it's in this age group, 35 to about 55. Remember, this was in 1995. Who in this room was between 35 and 55 in 1995? I was. So what group of people does that comprise? The baby boomers, exactly. The baby boomers were that age then. Okay, now, you take this big bump in people, so how you get a big bump in numbers without a big bump in incidence is exactly that. There are a whole lot more people to choose from. When you take that group, that whole lot more people to choose from, and you move that forward in time from 1995 till now, that puts them what? About 55 to 65. And in fact, we know from the Rand Corporation study that as of April 2011, 10,000 of us baby boomers are turning 65 every single day. every day, right now. If 10,000 of us, somebody's turning 65 right this instant. Somebody was born right this minute 65 years ago and is turning 65 right now. That's going to happen for 19 years. That is going to add 39 million people above the age of 65 to our population in the coming next 17 years. Severe sepsis, we are moving those people from this part of the incidence curve to this part of the incidence curve. For doctors who are entering medicine now, the first half of their careers is going to be overwhelmed by this condition. And you know what the problem is? That most of those doctors are not getting good training at recognizing this particular condition. Which again is why informatics helps us to have potential solutions here. So how many people would you suppose in the United States get severe sepsis? I kind of gave this away already. Because I've been saying for the last 5 years, by 2012, it should be 3 million people in the country. And lo and behold, last week, in the journal Critical Care Medicine, another big epidemiologic study was published showing 3 million people in the United States with severe sepsis, with a mortality risk of 30 to 50%. Show this slide for a couple or three reasons. And I never give a sepsis talk without showing this slide. And the first reason for that is that I trained with this man, Roger Bone, at Rush Medical College, and he's the one that taught me about sepsis. So without this man, I might be standing up here talking about informatics and asthma or something. Who knows? You know, something boring like that. But instead, I'm talking about sepsis. Number two, he is the progenitor of the definitions I'm about to show you for severe sepsis, what we need to use both as cognitive thinking people and in our informatics approaches to this to diagnose, to inform us that severe sepsis is present. He's the man that came up with those criteria. And Laura, I don't know if you're in the room, you may still be outside, but you will be pleased to know that where he was working when he came up with these criteria, this is the third reason I show the slide, is related to that little man right there, the Jayhawk. He was an assistant professor at the University of Kansas when he developed these criteria. So, three reasons to show that. So one of them is a little brag that there's something to where I live besides you can look down and see it when you're flying over. And I know that's what most of you have done. You know, I'm not going to ask for a show of hands. So sepsis, for those of you who are clinically oriented, there's a big misconception that sepsis has to be hypotension or low blood pressure. It does not. Hypotension can be one of the features of sepsis. It is not the sine qua non, is neither necessary nor sufficient for the diagnosis of severe sepsis. But it can be a feature. But most people think hypotension as the first thing. Second thing, it does not have to be bacteria in the bloodstream. One assumes that maybe the bacteria made their way in there sometime, but you don't have to have proven bacteremia to say that a person has sepsis. These are the two commonest misconceptions about what it is. So what is it? These are the definitions that we use. Now, as we're looking at these definitions, those of you who are interested in informatics, think to yourself, which of these things could be pulled out as discrete data elements, and which of these things are a little more qualitative and harder to do that. So we'll talk about it. So first off, all sepsis starts with an infection. As I said, it's the most feared consequence of infection. So you can't have sepsis unless you've got that. Secondly, there is a thing called the systemic inflammatory response syndrome, which sounds qualitative, but you're about to see it's very precise on the next slide. What we say is that you have something called sepsis if you've got infection plus SIRS. That's what we call it for short, SIRS. sepsis. Dear sirs, I don't want to have you. Sepsis is that combination. Mortality risk here about 5%, and probably that 5% is people who go on to get this. 5% though, by the way, if I thought my ride back to the hotel with Diane gave me a 5% risk of going back, I'd find one of you guys to take me. Am I right? Nothing to sneeze at, but it's not like this, 30 to 50%. And what happens here? Organ dysfunction. When you can detect an organ that's dysfunctioning because of this infection, it raises your mortality rate astronomically, 30 to 50% now. Then we have a thing called septic shock. Now everybody's heard of septic shock. Even lay people have heard of septic shock, although they have no idea what it is. The septic shock is when you do have hypotension or low blood pressure, and you bolus, you give a whole lot of fluids, and the blood pressure won't come up. And you have to start vasopressor agents. That's septic shock. Okay, mortality risk here, traditionally stated at 60 to 80%. Okay, let's talk about this SIRS again. Systemic Inflammatory Response Syndrome. Roger, my mentor, loved acronyms, so that's how he came up with SIRS. He just loved turning everything into an acronym. But what is it? It's very discrete pieces of data. 38 degrees, temperature greater than or equal to 38 or less than or equal to 36. It is a heart rate 90 or more. It is a respiratory rate 20 or more. Or it's a white blood cell count that's more than 12 or less than 4. Or they're 10% immature neutrophils. Bands, we also call them. Easy. It's easy to recognize. You would think. Conceptually, it's not difficult. So we ask ourselves when we see an infected patient, do we have SIRS? It's pretty easy because a lot of times that fever, that white count, that's the kind of thing that made you go, oh, I wonder if this guy's infected to begin with, right? So SIRS is easy. Then organ dysfunction. I'm not going to go through these in detail because we don't have time today, but suffice it to say, central nervous system, cardiovascular system, lungs, kidneys, thrombostasis mechanisms, meaning blood clotting mechanisms if you're not clinically oriented, liver dysfunction, and lactic acidosis. So, the real principal problem in sepsis pathophysiologically for the clinically oriented is there's blood clotting in capillaries all over the body, basically. That's your 2 years worth of pathophysiology in 3 seconds. Blood clotting in capillaries everywhere. Capillaries supply oxygen to tissues. If enough capillaries are clotted, tissues have to do their thing without oxygen. That's great for every cell type in the body except one. Does anyone know what the exception to that is? The one cell type that doesn't need oxygen. That's a trick question. Every cell type needs oxygen. Every cell in your body must have oxygen every minute, or it will begin the process of dying. And that's what makes sepsis so lethal, actually. Lactic acidosis is what you get. It's what you get if you climb 5 flights of stairs in your legs when they're burning. But if the infection is causing enough lack of oxygen to your cells that this stuff starts spilling out into your bloodstream and you can detect it, think about that. That's scary. People look at these numbers and go, oh yeah, the lactate's up. No, that's scary. That's a lot of cells that don't have oxygen. Every one of these organs that dysfunctions increases your risk of dying by 15 to 20%. 15 to 20%. Now, so let's take a look here again at this as far as what can be discrete data points and what can't. Most of the stuff on here presents itself very nicely as something that you could pull out of an electronic medical record if you wanted. Blood pressure, how much urine someone's making, what their creatinine level is. This is the one that's kind of tough here. Altered consciousness, confusion, psychosis. How do you deal with that if you're trying to pull it out of a medical record? Well, you can make it a discrete data field, right? If you put it in something like, say, a problem list with an ICD-9 code attached to it, it can become a discrete piece of data. How many doctors do you think do that in their day-to-day course of existence? Those of you in informatics probably know that hardly any of them do that. But the rest might be extractable from a medical record. So why is it so hard for doctors to do this? I'll tell you why. Because the definition that we have gone through here was first published in 1992. So if you're a doctor and you trained any time before 1992, it's unlikely you got trained on this definition. And the only way you would get it is if you are trying to keep up with critical care medicine or serious illness, okay? The doctors who graduated in the decade preceding 1992, they're my age and 10 years, they are the doctors in the primes of their career. So the doctors in the primes of their careers in the United States of America had no exposure to this definition. So they can't use it at the bedside, as easy as it is. You saw the definition. You think you could diagnose sepsis? Of course you could. I have an undergraduate student that works with me because she wanted to go to med school, and it took her about 10 minutes to be able to go through a chart and recognize severe sepsis on a patient, okay? And now she does it like that. The other thing about sepsis, no specific test or marker for it. If you have chest pain and go to the emergency room, what do? Cardiac enzymes and an EKG because they know the answer. Boom, answer, done. Here you have to think a little bit, right? As odd as it sounds, doctors and nurses don't really like to think, apparently. No, that's tongue-in-cheek. People, human beings, like it better when there is a yes or no answer. It's how we're built, yes or no. Or for the informatics crowd, 1 or 0. How about that? Okay, let's take a look at our guy real quick here, and then we'll move on to our approach to this. So our guy came in, and we think he has an infection in his kidney, and look at this. He's got that high heart rate and high respiratory rate and high fever. So he's got 3 out of the 4 SIRS criteria, bam, bam, bam. It only takes 2 to count. So we go, oh, he's got sepsis. Does he have severe sepsis? Well, what's that? Central nervous system dysfunction. What's that? Oh, that's hypoxemia. That's lung dysfunction. And this is a little more subtle, but he's actually got hypotension as well. It's a subtle hypotension. That's why I toss it in there for the clinical types, because you look at it and you go, it's okay. It's not okay. By definition, it is hypotensive. Guy's got 3 organs down. Calculated risk of death, 45 to 60%, based on what we know. Ouch. So you're going to stick him in a corner room in your med-surg floor? Yes, that's what happens. That is what happens in hospital after hospital after hospital across America. And I think it's probably why 30 to 50% of people die. Now, I'm not going to spend a lot of time on this, but I count 3 more organs that are dysfunctional in his labs. So he's got 6 organs dysfunctioning. Calculated risk of death, 90 to 120%. 120%? That's kind of scary, because I figure the only way he can get that is if he takes me right along with him, right? I don't know of any other way to get 120. So it would not be worth knowing how to diagnose it unless we had things to do about it. We do. We have evidence-based guidelines that I'm not going to spend a lot of time on. I just want you to know. You can reduce the mortality almost instantly by half of what it is in a hospital if you do these things. We know that we have to pay careful attention to timing. Sepsis, it turns out, is an emergency. Just like these, you are all very familiar with door to PCI time because I bet you guys are responsible for tracking it. Stroke, time is brain. You have a stroke team, I'm certain. And trauma, sepsis has to be on that list. These are the things that we do for severe sepsis. It's a long list, not that much to it. I'll tell you the keys. Antibiotics in less than an hour from presentation. Turns out to be key. Big boluses of fluids. Get them to the ICU for a central line if they meet certain criteria. And the criteria, by the way, are fairly what? They have septic shock, which is potentially definable as a discrete field. They have a lactate greater than 4, which is clearly a discrete field. And if that happens, they need to get this. Okay, so I'm trying to build up that there are lots of different things that we might be able to do with a computer. So, in the early resuscitation, which would you guess is the most important? Let me just show you an experiment done by a friend of mine, Anand Kumar. Remember I told you this is survival, not mortality, so it's the inverse of mortality. Septic shock has a mortality of 60 to 80%, which would mean a survival of 40 to 60%, okay? My friend Anand Kumar enlisted 14 ICUs across North America to look at their septic shock patients and say, does the time they get their antibiotics make a difference? And what he found was, yeah, if you get your antibiotics in less than half an hour, 80% of you survive, not 40 to 60, 83%. If you delay 4 to 5 hours, only 50% of you are going to survive. In fact, every hour that goes by, your mortality increases by 7.5%. And then the sad part is this. What he found was that in those ICUs, university ICUs across the nation, across North America, only 50% got their antibiotics in that first 5 hours. No wonder the mortality risk is so high. So if we can detect this faster, we can do something about it. This approach to severe sepsis, this slide, it always kills me, because this was the randomized controlled trial down here in 2001 that showed that this approach to sepsis works. I thought it was a great trial. We started adopting these practices right away. Sadly, in the literature, 20 other people said, hey, look, us too, us too, us too. If I'd known they were going to publish 20 papers, they would have published mine. I would have submitted it. I just thought it was a settled argument there. Now, if we use these bundles of care, now we start getting to the University of Kansas and our experience. If we use these bundles of care appropriately, we make a difference. This is a period of time a couple or 3 years ago, and I want you to look at two curves. This is how often we achieved the bundling of all of those elements together in our patient population in a given month as a percentage. So out of our septic patients, if we gave all the elements, we got a dot here. You will notice that this curve goes up and down month to month. What you will also notice is this little blue curve here. The blue curve is mortality. And one day I pulled up this curve and I looked and I went, well, isn't this interesting? If we accomplish what we're supposed to accomplish, mortality drops. And when we quit accomplishing what we're supposed to accomplish, mortality goes back up. And in the month where we did the full bundle of the elements, 72% of the time, our mortality dropped to 8%. 8%. We haven't been that low again. We were firing on all cylinders in that month. But, so the point is, if you do the right things, you can save lives, and we've done it at KU. Okay, so we started attacking sepsis in 2004. My chief critical care nurse came to me and said, we should do these things in the Surviving Sepsis campaign bundles. And I went, any fool knows that's what you do with severe sepsis. That's what we do in our ICU. What are you talking about? He said, really? Are you sure? Why don't we take some measurements and see? And I'll be darned, folks, when we started looking, we actually took measurements, which is what informatics is good for, if I'm not mistaken. When we took measurements, 20% of the time, 20% of the time, we were using these bundle elements. So that was bad. So we said we better pull together a team of people, which we did, with docs that included internal medicine, surgery, and emergency department, nurses from all those same places, pharmacists, respiratory therapists, variety of people saying we've got to attack this problem. We need to use these bundles. So, as it turns out, as we start working on this, and we work on it for years and years and years, here's another bit of a trick question. In the early resuscitation of the severe sepsis patient, the most important feature is, what did I just tell you? I said antibiotics, right? Well, it was perhaps the most important thing to do rapidly, but you can't do it rapidly unless you do this. And it turns out, my friends, in hospitals across the nation, this is the crux of the issue. Knowing that it's there with a probably major corollary of, oh yeah, I see that there, but the guy looks okay. Looks okay to me, not paying attention to the discrete data elements that can tell you that the guy's not so okay. This is the crux of the issue. So, we analyzed our processes, we put into place protocols, order sets, mechanisms for measuring, and we educated. I personally went to every nursing unit in the hospital and educated every nurse in the hospital. I educated our coders downstairs so they would know what to look for and they could prompt doctors about what they were doing as they kept the medical record. We got everybody on board, posters, grand rounds, badge buddies. Great. Okay, so that was all good to start with. That was great to start with. And I'll come back to that point in a minute. Actually, I'll make this point right now. In a hospital like ours, and probably in a hospital like yours, there's a whole lot of turnover. I emailed my nurse manager of our ICU yesterday, and I said, you know when we started this sepsis thing in 2004 and we educated the heck out of everybody? How many of those people are still in our ICU? 16%. 16% of the folks that work in our ICU were there when we did the really strong education. So the problem with education is you've got to do it consistently. And I'll tell you, I can't go to every nursing unit in the hospital every week. It's not possible. So here's some of our data from KU that might be interesting. We are a 600-bed hospital, basically, in that ballpark. We started collecting data in fiscal year 05, which ends up on June 30th, 05. Started collecting data on our sepsis. We have to have some way of knowing in the hospital how much sepsis is in there. I mean, because it's easy to say this is how much we think is there, but how do you know how much actually is there? The way we do that is we use our hospital's discharge database to find people who have diagnosis codes for an acute infection and an acute organ dysfunction. I hope you're starting to get a feel. We do use informatics for this. When we combine all of those, that's the red curve here. Then we look for what people actually got diagnosed with severe sepsis, i.e. are coded with severe sepsis at discharge. That's the blue component here. And then we looked at who got a diagnosis code for septic shock. So, a couple of interesting things. In that period of time, our total inpatient volume has risen from 19,000 to 28,000, an annual growth rate of 5.3%. Our severe sepsis population has risen at a compounded rate of growth of 15.5% because of all the factors that I explained before. Now, if we assume that this method we use captures 100% of patients, that's what I did on this slide here, what proportion of them are we diagnosing and therefore coding? That's an important thing to know, isn't it? At our baseline, we were capturing about 43% of them. Ouch. We did make progress, have made some progress through the years. Our peak year was about 85% what we captured. Now, this green line here shows something different. It shows the proportion of sepsis that was at septic shock, meaning the worst manifestation, the hypotensive, easy to detect patient. In our first year, 63% of all the sepsis cases we detected were septic shock, meaning what? What it means is people were not using those diagnostic definitions, and they weren't ever calling anything sepsis, not ever, but most of the time, they were not calling anything sepsis unless it was septic shock. That's bad. So we had to do something about it. We did. That's all very good. Here's another interesting thing. You will find this in your hospital, I guarantee. This is risk-adjusted mortality or mortality index, meaning those who died versus those who were expected to die based on their hospital entrance criteria. This is the overall hospital number. This is all the patients except sepsis. This is all the septic patients. Wasn't that interesting? Our hospital's risk-adjusted mortality is quite clearly driven by severe sepsis. In fact, out of all the deaths that happen in our hospital, every year between 45 and 48% of them involve severe sepsis. You know, as we are attempting to drive down our mortality rates, sepsis is the number one thing we have to take care of. Now, we've done a good job. Here on this slide, this is good. This is time again, starting in 05 up through 12. This is absolute mortality rate. We started at a mortality rate for severe sepsis, which is red, of 49.1%. In our last fiscal year, we had managed to get that down to 18.4%. That's a good thing. Blue is septic shock. It's coming down, not quite as fast. But then we go to this. This is again the mortality index data. So what about the mortality index data? Well, we were doing good, sort of. We were doing really bad back in fiscal year 05. Our observed mortality was higher than it was predicted that it should have been. Ow. Boy, that was a real slap in the face when we saw this. And we've done a reasonable job getting it to below 1. Our lowest was 0.82 in fiscal year 11. Then we started sliding up again. So luckily, we started working on our real-time surveillance using an informatics approach in 2009. It just took us a couple of years to get it up and ready to run. So our mortality index is sliding. Why might it be sliding? Either we're getting worse, or the data on which expected mortality is calculated is getting better. In other words, all across the country, everybody's doing a better job. That's a good thing. That's probably a good thing. It means the bar, if we're going to be in competition, the bar is higher now. Here's something that will be important to you, especially to your bosses. This, over the period of time, I just have this period of time from 07 to 10 plotted out here. It comes from a presentation we did at a national meeting. Drove down the length of stay from 24 days to 16 with our efforts before our informatics approach. Drove down the cost from $52,000 to $34,000 over the same period of time. the numbers have increased such that if we were still taking care of people now like we did in 2007, we'd be spending $20 million more a year. So our CEO likes it that we're not spending money at that rate. And yet, we still think we have dollars to carve out. So, since detection and recognition is the difficult thing, real-time clinical surveillance would be a great thing to do, don't you think? If the EMR makes it possible, and it can be automated because there's a whole lot of data that's put in there in real time. So if you're using the EMR to monitor, and one of the ways that happens is best practice alerts, right? You start to type in, give this person penicillin, and the best practice alert is monitoring instantly and says, this person's allergic to penicillin. If you combine the EMR with continuous monitoring, that can be really potent. And those of you, has anyone heard of the EICU? Probably some of you have the EICU. This is probably the highest level instantiation of real-time clinical surveillance. You have a bank of monitors with an EMR, and you have nurses and docs sitting there monitoring every patient 24/7. Okay, costs a lot of money, an awful lot of money. So in 2009, we were approached by Computer Sciences Corporation to see if we would partner on a real-time response. And we went, well, yeah, because one of our big problems is recognition. You think you can help us with that? And all the things that we just said before, we can leverage the power of our electronic medical record if we can do this. So, what did we set about working on? Developing some pattern recognition algorithms that are applied to O2, that's our own hospital's so-called version of EPIC. O2 stands for optimal outcomes. That's how they sold it to all the clinicians when they brought it on, optimal outcomes. So it applies these algorithms to O2, and it's not just going to be for sepsis. It's also for VTE prophylaxis, for our core measures of pneumonia, heart failure, etc., glycemic control, and to help us control our readmission rates. So that seemed to make it worthwhile to partner up on this project. So, of course, we went through an iterative process with them. We met over and over and over, and they would come back and say, does this work, does this work, does this work? Both on the detection and the reporting. Took a lot of meetings, of course. We came up, this is our ultimate algorithm. I am not going to go through the ultimate algorithm. You can sort of guess at what it might be based on our things. One interesting feature is we found out kidney disease really throws you off. There's so many people with chronic kidney disease. When you're looking for an organ dysfunction, you have to put in some extra rules to try and rule them out. So that's good. So the really hard work was actually done by the computer guys. That's what I think. Algorithms, what we're looking for, that's easy to define. I have definitions there for you. The hard part is, where do you go in the electronic record to find the best piece of data to answer this? And this is what they came up with. This is what we have. It's called Carevalence for real-time surveillance tool. When the nurses use it, they get a screen like this that tells who the patient is and where they are, what service they're on. How many SIRS criteria do they have? How many organ dysfunctions do they have? And do they have an infection diagnosis? And this turns out to be one of the hardest things. Because doctors write pneumonia, that's fine, you write pneumonia in your progress note, but in your progress note it's hard to find. And only if you have the discipline to put it in your problem list does it become a discrete piece of information that our computer can detect. So this becomes one of the difficult areas. Once the person is screened, you can pick any person off of that screen and drill down to some real information, such as when did they meet the SIRS criteria? When did they meet the organ dysfunction criteria? What is their infection if there is known to be one? So the nurse monitoring this can do all of that. And then take steps, say what the steps were, and let's say the patient doesn't need any steps. It turns out there's no infection. The SIRS was from some other cause. It's not severe sepsis. We don't have to worry. We can put this patient on the don't bug us again for 24 hours list. There's actually a better name than that, but that's what it is. So this is how we put this into place. Amanda is the supervisor. Michelle, Dustin, and Emily are the people who work. Now, you can tell with 3 people, we're not doing this 24 hours a day, 7 days a week. In fact, we have 12 hours a day, 7-day coverage, okay, which you will see turns out to be a bit of a problem. So what does the nurse do? She sorts and reviews by location with this priority. We think people in the emergency room are probably the top priority to make sure we get them squared away. Non-ICU medical and surgical patients, then ICU patients. Because ICU patients presumably are being monitored closely already. We look for suspected or confirmed infection, and then if it's warranted, that nurse, the surveillance nurse, calls the bedside nurse to say, here, your patient looks like they likely have sepsis, and or to get some clarification. We did a pilot project of this in February of 12. An 11-day pilot project. In 11 days, CareValence identified 655 potential episodes in 477 patients. Here is what happens. When our clinical personnel review, we get those down to 19. We recently have adjudicated these with outside experts, meaning me and a couple of other people went back through all these records to say, was CareValence correct or not, et cetera, et cetera. 19 is the appropriate number after review. Why did people get ruled out? These are the reasons. No infection, organ dysfunction wasn't acute, patient was already in the ICU. Average time it takes to review a chart in our pilot was 1.9 minutes. So 20 hours over 11 days, chart reviewing, plus the other time that the nurse would put in communicating with the floor. In real time, now that we have put this into work, 60 to 75 patients an hour need to be screened by a nurse. Now this is why the EMR flags have failed. And flags in certain products will bring to the bedside nurse, your patient looks like she has sepsis, looks like she has sepsis, is because this many per hour are detected and the smaller number are what was real. Now, one last point I'm going to make, and then I will shut up, I promise, is this. You know, I showed you in that month where we fired on all cylinders and got our bundles done 70% of the time, that our mortality went down to 9%. What we know since we put CareValence into place is that our compliance with bundles compared to the most recent years has gone up. We don't have the final mortality numbers tallied yet, but what we do have is this predictor that when CareValence is used, we're in the ballpark to have our sepsis mortality below 10%. So our limitations are discrete fields are necessary at the moment. Staffing is tough. High number of people get flagged that don't have sepsis. The future, this is where I want to go, where I hope we can go, is the ability to interpret the free text, to see what doctors and nurses are writing, so that we can increase our specificity and reduce the number of surveillance personnel. And then, in fact, it may be an appropriate thing to put these warnings back to the bedside where they belong. Any questions? I'll take some now, and this is my email address so that you can contact me later if you choose.
Thank you, Dr. Simpson. So we're going to have a few moments for questions, and then between now and our next presentation, we're going to take a quick 10-minute bio break, just so we don't have our kidneys back up and have sepsis. And we'll go ahead and have a few questions. We'll walk around. Please try and make your questions brief. And then also we're going to be monitoring for questions in our site down in San Diego. Thank you. Raise your hands if you have questions.
Hi, that was terrific. I'm a registered nurse myself. I'm from UCI, and I'm in the clinical informatics department. We've been looking at something along a similar approach. We haven't gotten to where we're doing anything with it yet. We're still sort of figuring out and analyzing. This is very helpful. My question would be the pre-existing organ dysfunctions having altered mental status, dementia already,
right.
having renal disease already.
Yes.
Are there any processes to be able to look at that and then be able to sort of take those out of the,
Take them out of the loop.
Yeah.
Okay, what I didn't spend time on detail on is that little bunch where somebody has chronic renal disease. We ask a couple of questions. Is erythropoietin, which chronic renal disease people take, is that on their pre-hospital med list? And there's one other question that I'm blanking on right now, but we can look it up afterwards. But yes, so you can take renal disease. So there are 2 or 3 places to look. Our pre-hospital medication list we do look at to see if there's any indication that somebody is taking a medication for this condition chronically. And then of course, we do look at the admission and if we have previous data in the preceding year, we're going to look at creatinine. And so the algorithm makes a comparison of baseline to current on creatinine. Dementia can be a little bit tough. Again, all of this is why our problem list, those of us who actually use it, you can imagine somebody who's interested in the informatics approach is religious about filling out a problem list, and it asks, is this a pre-existing problem at hospital admission? And so that's where our algorithm has to pick it up at the moment. As I say, if we get some free text recognition, which certainly seems within the grasp of informatics, then when somebody writes past history of dementia, it ought to be detectable that way, I would think. Yes, sir?
That was a great presentation. Thanks very much.
Thank
you mentioned at the end that possibly your detection, the sensitivity and specificity of your detection might be improved by harvesting clinical notes. I'm also curious, now that you're using an EMR and you potentially have larger volumes of data, are there other types of triggers based on the large volume of data, changes in vital signs over time, or other types of big data strategies that might allow you to improve detection algorithms?
Yeah, so you guys didn't hear the first part, but the question is, okay, some of these sensitivity and specificity might be improved with some free text recognition. The other thing, what about data mining of all the vital signs, let's say, and all the white blood cell counts and all the various things that go in there? At the moment, well, the simple answer is yes, but the not so simple is the doing of it, right? So far in the medical literature, there are not a ton of predictive models that say if your vital signs do this, then you can expect it's likely to be sepsis 70% of the time. That doesn't exist yet. I will say I'm working with some people at Kansas State University, and we've developed an agent-based model of sepsis that we are trying to bring into the translational realm, meaning we're trying to get real people data to help us inform that agent-based model. Yes, I believe it's doable, but I don't know for sure of anyone that's got it right now.
Okay, we have a question back here.
Hello. Thank you very
Oh,
much for your
hi.
presentation. I had a question regarding the data with the increase in sepsis rates with the increase in the baby boomer population. Is there any hypothesis as to why there is that increase, why there's that large number of baby boomers in the mid-90s? It just was some interesting data, I thought.
Well, it's just because the baby boomers were the big bulge in the overall population.
Okay.
Yeah, so that's it. So the reason there were more cases is because there were more people to have cases, and not because the incidence, they weren't more susceptible back then. There were just so many more of them that there were a lot more cases.
Is that related to the continued increase, a continued population?
Well, so the numbers I showed you on the 8.5% per year increase,
Right.
That was happening before the baby boomers started turning 65. Now that we've started turning 65, it's likely to ramp up. It may even double in terms of percent increase per year because of that factor.
We have another question back here.
Sure.
Good morning, thank you. I found your presentation fascinating,
Thank you.
and thank you for sharing, appreciate it. It's the data and the discrete data in finding it. I think we're all going through the process where the business feels that the computer should know. The most informatic part that I found was that you have a nice warm body looking at this data and interpreting it.
Right.
How did you promote that aspect of having 24/7 that looking at the data for clinicians? Thank you.
So as you can see, we were not successful in promoting 24/7. We only got 12/7. And I think that the reason that went down is the way a lot of things go down. The hospital executives made a commitment to CSC that we're going to get into this project and we're going to see how well it works. And then, of course, other things, after a couple of years of development, other things get onto the radar screen and begin to take away. That's why we haven't gone to 24/7. We are quite certain we would be more effective with 24/7. But that, as I said, that's one of the limitations of this sort of system. It's better than flagging every bedside nurse 25 times a day, right? So it's definitely better than that. And that's the actual, if there's any innovation in this, it's in the recognition that you can't do that. You must put a human being at our current level of technology. You must put a human being in the interface so that what gets to the bedside is real usable clinical information. And so we built that case by showing how many best practice alerts we're firing in Epic to our nurses for sepsis that were just being clicked right past. So that's the one thing. And that's why I say it is a limitation to this approach, because if we get an approach that actually can weed out all those false positives, then you can remove that human being potentially from the interface and go straight from electronic medical record to the bedside nurse with a real valuable piece of information.
Okay, one more last question.
Yeah, thanks. The emphasis that we see all the time now, certainly with meaningful use and everything else, is about the implementation of the EHR and
Yes.
all the elements that go into that, which, as you know, is primarily the capture of data.
Right.
And for surveillance to make sense, it isn't about the capture, it's about reading what has been captured. And if we all know the environment, sometimes what is entered and documented doesn't occur fast enough, right?
Yes, exactly.
So, and then the other side of it is for a system like your Carevalence to work, it really depends on what transactions are being monitored, what the interface capabilities are of the EHR, and then the timestamps and everything else on all those transactions. In your experience, have you found an optimal way to sort of take the practices around the EHR to get them timely enough and to get the proper elements captured in order to make the surveillance actually work?
Right. Yeah, so the elements that, where there are time delays. I mean, obviously the EMR will pick up the laboratory information instantly. The EMR will pick up the vital signs information at least once an hour from the people who are electronically monitored, right? So some of that stuff is fairly easy, but I know you're driving at how long does it take for the doc to write the note that you might pull information from. How long does it take for the nurse to actually, I mean, you still, in this day and age, I hate to admit it because I love my hospital, but every now and then you walk into the ICU and here's a list of the blood glucoses that have been being collected all day long, and the glucose is going 100, 125, 175, 225, and it's just written and taped up on the door frame. You know, why is this being taped here? Because if you would put it in the EMR, I would have known 5 hours ago that this was happening. So that's a human factor. And you know how hard human factors are to deal with. I may be wandering around your question. So what can we do to improve that is we have to make documentation easier. If you have spoken to any docs, or if you are a doc yourself with the electronic medical record, you may know that our days have been extended by 40% by an electronic health record, because at the moment, it is so difficult to use, to get thoughtful information into, that much of our documentation occurs near the end of the day. Much of my documentation these days takes place from 8 p.m. till 1 a.m. when I'm on clinical service. So I think that's where we have to attack the problem, is the ease with which information is input. Well, one thing you can do, like if you're a hospital IT manager, the things that you struggle with, how long does it take to get into the electronic medical record? If I was standing at the bedside and I've got something to put into it now that's important, and it takes me 2.5 minutes to get the computer up, it ain't going to happen. Okay? It just isn't going to happen.
Thank you, Dr. Simpson.
Thank you
So
all
we're going
very
to
much.
take a quick bio break. Dr. Simpson.